Assalamu alaikum, everyone. Welcome to the neurosurgical case room. And we are going to do the Spinal Tumors Marathon today. Inshallah, we will try to cover at least 3 tumors because 3 or probably even 4 of them have already been covered in previous sessions. I will just briefly mention them and briefly tell where the surgical strategy differs. So let's begin, and please brace yourself because this is going to be a really, really heavy session with over 70 slides. And please make sure that you're all muted because it does create a lot of disruption. So let's begin without any further ado. Okay, I think we are all clear about this, but I would just briefly go over the main classification or the compartmental classification when it comes to spinal tumors or the spinal cord tumors. So these are the intramedullary tumors, pretty understandable by the name. You can see that these are within the spinal cord parenchyma, and they lead to something that we call pregnant cord. Because they are arising within the spinal cord parenchyma, the infiltration is really significant and it's really, really difficult to find an appropriate surgical plane. You can find surgical plane with the spinal ependymomas, but when we're talking about spinal astrocytomas, usually there is no significant surgical plane, which precludes any form of gross total resection. So the next category is the intradural extramedullary. And you can see that there's this space. Let me mark this. This is the dura, and this is the cord. So these tumors are still intrathecal. They are within the thecal sac. They can have an extradural component, specifically when we talk about the schwannomas or the dumbbell tumors, but usually these are intrathecal. And you can see that they push the cord towards one side, and hence what is going to be an apparent presentation of them? The clinical presentation is going to be asymmetric. Why? Because you can see that when it comes, let me change the color. When it comes to the intramedullary lesion, the entire cord is involved, and the involvement or the symptoms are going to be symmetric. Whereas when you see that there is an intradural extramedullary lesion, because it is compressing the cord, there's a squeezing mechanism going over here. And since it squeezes the spinal cord on one side, the presentation is also going to be asymmetrical. So asymmetrical, and there's another buzzword that examiners like to throw at us, and that often gets asked in the rounds. I have not seen it in the clinical presentations as often though, which is the Brown-Sequard syndrome. And why does that happen? Because unlike trauma, you can see that because the spinal cord is getting squished on one side, so the axial section is going to look like this. This here is the cord. The right side is the tumor. And since only one side is squished, on the opposite side of the body, there is going to be the hemiparesis or the motor deficit, etc. So patient is going to have Brown-Sequard syndrome, and the presentation is often going to be asymmetric. Let me clear all this up. Okay, now we come to the extradural tumors. Extradural compartment is notorious for one thing: Mets, and Mets. There are 2 other things that can be present in the extradural compartment. They are lipomas, and sometimes when there is a hemangioma in the vertebral body. And please, Dr. Iro, do not write on my screen. Okay, so when we are talking about the extradural compartment, what it is going to do is it's going to compress the cord just like the intradural extramedullary lesions. What is the difference? The difference is that this tumor has significantly more space available to it in comparison with the intradural extramedullary counterpart. Because this space here is still going to be pretty narrow, you're going to see that since this is within the dura, there is going to be arachnoid here and here as well. And this is the CSF column. Let me clear this up. This white space is actually the CSF column. So the space is going to be very limited when it comes to IDEM. But when we are talking about the extradural tumors or the metastasis, we know that it can involve the vertebral body, it can sometimes involve the posterior elements, and there is this entire space where it can traverse. Hence, the presentation might be very different than the intradural extramedullary tumors. We are not going to cover spinal mets. As of today, we might jumble them up in one session, both the spinal metastasis and the cerebral metastasis. Let's focus on the primary spinal cord tumors. So, are we clear till this? I think this was pretty easy, right?
Yes.
Okay, moving on to the next slide. So you can see that this again is a very beautiful illustration of how a lesion is going to appear. Intramedullary within the spinal cord parenchyma, intradural extramedullary outside the spinal cord, but within the dura, and it's the space is still confined. Then we have the extradural extramedullary, which is outside the thecal sac. It's going to involve either the vertebral body or the posterior elements of the vertebral body, of the vertebra. So you can also see, let me draw it here. Now depends what is the actual IDEM here. If it is a schwannoma, then it's going to be a nerve root tumor. It can be intradural. It can have an extradural compartment as well. Why? Because the nerve root is going to exit here, and the lesion is also going to travel along with the nerve root and get outside the dural space. So intradural extramedullary tumors can very easily have an extradural compartment, right? Also, there are some tumors which are the one subtype is intramedullary, whereas the other subtype is intradural extramedullary. I'll give you an example. Even though we have previously discussed ependymomas and specifically spinal ependymomas very thoroughly, so we are not going to cover them here, but ependymomas are intramedullary tumors, right? Whereas myxopapillary ependymoma, which is also a subtype of ependymoma, that is intradural extramedullary tumor. It's not intramedullary per se. It can have a component of intramedullary. It can have a single component or a portion which goes inside the spinal cord and is intramedullary. But as a whole, myxopapillary ependymoma stays intradural extramedullary. So, are we clear till this?
Yes, clear.
Okay, so these are the easy parts. Let's move on. Now, these are the more common types. We can see that intramedullary tumors are ependymomas, astrocytomas, hemangioblastomas, metastasis. I'll just briefly quote, ependymomas are the most common intramedullary tumors. Astrocytomas are the second most common, but they are the most common in children. So always remember what is being asked. If you're getting asked what is the most common spinal tumor in children, then it is astrocytoma. If you're being asked that what is the most common intramedullary spinal cord tumor, then it is going to be ependymoma, according to multiple published literatures. Hemangioblastomas, interestingly, are associated. Please mute yourself. Who is this? Anybody who is not muted, please mute yourself because it creates a lot of disruption. Okay. I think someone is still unmuted. Let me see. Please be mindful of your space and everyone else's space, because when a session is interrupted, then everyone else also loses their train of thought. Please mute yourself. So, coming back to hemangioblastomas, interestingly, hemangioblastomas are usually associated with syndromes. You will not see them sporadically, very often. Hemangioblastomas, if they're in the spinal cord, they need a run of the VHL workup. And it's really, really important to identify whether this is an individual lesion and a sporadic appearance, or this is coming as the part of an entire syndrome. Then we have the metastasis. Intramedullary metastases are very, very rare. They are not as frequent in the clinical presentation. But the tumors that can cause intramedullary metastasis are lung, breast, and melanoma. Also, melanomas, the metastasis from the melanomas have a very high tendency of bleeding. We all know that. So if they are within the spinal cord tumors, within the spinal cord, they can also lead to hemorrhage within the cord and can present very suddenly. But we are not going to the meds today. Let's stay on the session. So intradural extramedullary tumors, we can divide them in schwannomas, neurofibromas. A lot of people confuse them. We have a very good differentiation table for them later on in the session. Then we have meningiomas, and then we have the phylum ependymomas that I have already previously discussed, myxopapillary ependymoma. Extradural, extramedullary, bone metastasis, chordoma, sarcoma. Okay, so this all. So it's really, really important that you know how to differentiate an intramedullary tumor from an extramedullary tumor, especially when a patient is presenting to you within the ward or in the outpatient department. Oftentimes, their clinical presentation is so distinct that you would be able to tell its compartment before you have gotten an MRI. So you can see, let me move this. Okay. What is the vertebral pain going to look like? With an intramedullary lesion, the pain is going to be diffuse and dysesthetic. You write this. Patient is going to say that they have burning sensation, they have pins and needles, and they don't know what is happening in their hands and feet. So the pain is going to be very dysesthetic, unpleasant sensation. It's not going to be localized, and patient will not be able to pinpoint an exact site. Whereas when you see extramedullary lesions, these often have very defined localized pain. And interestingly, if it is a schwannoma, then the pain is going to follow what? It's going to follow the nerve root distribution. For example, if a patient has, let's say they have a schwannoma, which is, even though it's going to be rare at this location, let's say there is a schwannoma around L4 or L5, then the patient is going to have a shooting pain down the L4 or L5 trajectory. Why? Because extramedullary lesions present with radicular pain or a very specifically localized pain. Often the pain is worse at night. That is true for both, by the way, extramedullary lesions and intramedullary lesions. Nocturnal pain in the back or in the neck is a very important red flag of spinal cord tumors. So we can see that there is significant difference in how upper motor neuron signs and lower motor neuron signs present in the intramedullary, and we will see later on why is that. So intramedullary tumors have upper motor neuron signs, extramedullary have them as well. That's obvious, right? Which one is going to have it early? If you see the spinal cord section here, please excuse my drawing. The corticospinal tracts are located on periphery, right? So what ends up happening is if there is a lesion and that is compressing from the outside, then the cortical spinal tract is going to get affected very early on. Hence, we can see that the upper motor neuron signs are an early feature of what? Extramedullary lesions. Whereas in comparison with this, you can see that intramedullary lesions start growing from here. By the time they reach the corticospinal tract, it has been significant progression, and the patient has had symptoms for a long time. So yes, there is going to be a motor neuron involvement, but it's going to be late. Are you all with me till here?
Yes.
It's going to be a very fast-paced session because we have a lot to cover. Let me draw it again. Now, if you see that there is lower motor neuron signs, they are prominent and diffuse in intramedullary, whereas in extramedullary lesions, they are either uncommon or if they present, they are segmental, just at the level of the lesion. Can somebody mention why? Can anyone volunteer and tell me why lower motor neuron signs are a prominent feature of intramedullary lesions? No? Okay, there is, let's see, limits. So this is the, I don't know how to draw it nicely. So these are the gray column, right? This is the gray column, and the gray column is where the neurons and their cell bodies are going to be. What ends up happening is, since intramedullary lesion is going to involve the central spinal cord, it's going to involve the gray column first. And once these cell bodies are involved, lower motor neuron sign is going to be a primary feature. The tract involvement is there, but it's going to be very, very late. I do have a cross section of the spinal cord, which will help me explain this to all of you better, because obviously the drawing is better. And then we have the sacral involvement, the go-to question of examiners and the go-to question in the rounds. There is sacral involvement in both, but intramedullary lesions have characteristically a feature which is called sacral sparing. Why is that? Because the sacral fibers are far away from the midline, hence they get spared, and the patient might have a sensory deficit, but the sacral region will have preserved sensation. In comparison with that, extramedullary lesions have early sacral involvement. So bear with me till this. I have an image that explains this better. Then obviously we have the cauda equina involvement for the intramedullary lesions. If they are conus, there is a sphincter involvement that is early. For extramedullary lesions, cauda equina is the usual presentation, and that is slightly later. Change this. Okay, so I was talking about this image, and change the color. You can see, what is this? This is the central cord, central canal, right? This portion here is the anterior commissure. This is very important for us when we are talking about the intramedullary lesions. This is where all the cell bodies lie. And you can see that the corticospinal tract is here. This is the lateral corticospinal tract. This is the anterior corticospinal tract. These are one of the most important tracts that we should know when we are talking about intradural extramedullary lesions and intramedullary lesions. Assuming that we have, let's talk about intramedullary first. Where is that going to grow? It's going to go here, right? This is the usual location of intramedullary lesions. Are you all with me?
Yes. Yes.
So what ends up happening is there is anterior commissure here. What is crossing in the anterior commissure? Can someone volunteer and let me know?
Bladder fibers?
Sorry?
Bladder, urinary bladder?
No. There are two very important tracts that cross in the anterior commissure. What are those?
Axilla-spinothalamic tract.
That's right. We have the anterior corticospinal tract, and
Lateral.
there's another one.
Lateral corticospinal?
No, spinothalamic tract. So we have two tracts that are crossing here, the spinothalamic tract and the anterior corticospinal tract. So what does the anterior corticospinal tract supply? What does it do?
Touch, pressure,
Sorry, who is this?
pressure, pressure.
No,
Axial musculature, madam.
that's right. Who was that? Please introduce yourself because I do not have participants tab open today.
Dr. Abid Shehzad, madam.
Okay, yes, Dr. Abid Shahzad, you're right. The anterior corticospinal tract supplies axial musculature. And we have the spinothalamic tract. The anterolateral spinothalamic tract, they also cross in the anterior commissure, which means that if a lesion is intramedullary, it's going to involve axial musculature early on, and it is also going to involve the pain and temperature sensation. So you will see that these patients will often present with decreased postural stability, and they will present with dissociated sensory loss. Are we clear till this?
Yes.
Yes.
Okay.
Yes.
Now, coming to the intradural extramedullary lesions, you
No,
can
no,
see that
dissociated sensory loss is because of posterior column is not involved. Because posterior column having fine touch,
yes,
uh,
that's right. The
that
posterior
is
column is
spared.
spared. Yeah, you're right.
spared.
I think I know who you are. I'm just forgetting the name. Please introduce
And
yourself.
I'm Dr. Subham from CMC Vellore,
Yes,
India.
Navishbam, I
Another thing,
recognized your voice.
I have seen a case in which there is a bigger lesion in the ependymoma. We operated. It is a long segment ependymoma. We completely removed the tumor. In that case, I have seen the tumor is intramedullary, but it is compressing the posterior column. I have seen the. I have examined the patient in
Mm-hmm.
which the proprioceptions in the toes have been absent in the patient. Proprioception in the
Mm-hmm.
toes means proprioception is posterior column. No? Proprioception and is the
Yeah,
posterior column
proprioception in the
sensations.
toes. By that, I think you mean the joint
Absent.
positions, right?
Joint position, yes, that is absent.
Yeah.
Yes.
So ultimately, if an intramedullary lesion ends up growing bigger, let's say that this is an intramedullary astrocytoma and it's growing and growing and growing, obviously it is going to involve the posterior column because they are right here. And later on, it is also going to involve the ventral columns, the corticospinal tract as well. Hence, we discussed that there might be upper motor signs in these patients later on. Why? Because if the tumor is left on its own to grow, then it is going to involve anything that is going to come across its path. Whereas, when we compare the intradural extramedullary lesions like schwannomas, like meningiomas, what is going to happen is it's going to compress from the outside. For example, this is a nerve root and there is a schwannoma going on here. Okay. So when the schwannoma, it grows, it's going to compress corticospinal tract very early on in its presentation. Hence, the patient is going to have what? It's going to have contralateral weakness. Interestingly, if you also see, it's going to have the pain and temperature sensation absent on the, can somebody remind me of the brown sac word exact? Contralateral weakness and,
Pain and temperature
weakness,
opposite side
ma'am.
height.
sorry, who was this?
Ma'am, I'm Dr. Ejaz.
Okay.
There is a loss of ipsilateral weakness and contralateral pain and temperature and ipsilateral dorsal column modality is loss.
It's contralateral weakness, right?
Ipsilateral, ma'am. Because the
Okay.
fibers crossing in the middle of oblongata. So if you have a problem in the spinal cord, there will be ipsilateral weakness, ma'am.
Oh, yes, I think I have missed that one. Please excuse me for that. So, patient is going to have Brown-Séquard syndrome. I do not remember it in its entirety and clarity, so I'm not going to go in the detail. Please excuse me for this. I'll leave a detailed explanation in the WhatsApp group, inshallah. Let me clear and move on to the next image. So we have the intramedullary tumors. And you can see that we have already discussed this, the spinothalamic tract and the anterior corticospinal tract. These are the axial musculature which are getting affected. Hence, there is going to be a proximal or the trunk muscle weakness. There's a term which is called girdle. Patient might have girdle weakness as well. That is the shoulder girdle and the pelvic girdle. Then we have the spinothalamic tract, which is also getting involved in the anterior commissure. And pain and temperature is going to get affected. Why do we call it dissociated sensory loss? We call it
Because the
dissociated
posterior-
sensory loss. Who is this? Okay, we call it dissociated sensory loss because the pain and temperature is affected, whereas the dorsal column sensations are still intact. Why? We have already discussed the why. Okay, so this is a comparison of the sacral sparing versus the sacral involvement in the intramedullary and the extramedullary lesions. I think we have gone in the detail on the image, and I do not need to go in as much detail. It stays the same. The sacral fibers are somewhere around here. So when a lesion is growing here, it's going to take a lot of time to reach the sacral fibers. Hence, the involvement of the sacral, the region is going to be pretty late. Whereas when a lesion is growing on the periphery, for example, an intradural extramedullary lesion, then it's going to involve the sacral fibers very early on. So these are the three main, or at least the most important intramedullary lesions. We have astrocytomas, we have spinal ependymoma, we have spinal hemangioblastomas. For ependymoma, we have a dedicated video. For hemangioblastoma, we have two videos, in fact, but they're not spinal hemangioblastoma. So I'm going to cover it in this slide only as well. Since it is intramedullary, all the surgical principles stay the same. The only two adjuncts that we need are going to be microdoppler and indocyanine green angiography. Nothing changes for hemangioblastoma surgery otherwise, because they are very vascular and because the spinal cord is very, very sensitive to any form of unnecessary bipolar coagulation or unnecessary pressures. We do not even coagulate the small perforators. We use a microdoppler and we use indocyanine green angiography to operate on the hemangioblastomas. Apart from that, we are also going to identify artery of what artery is going to be important when it comes to the spinal surgery?
Adam ki Wicks.
That's right, artery of Adam-Kiewicz. That is going to be our primary focus, especially if a lesion is around D6 to probably L2, because it can arise anywhere around D10, 9, or 10. And we are going to need a pre-op angiography to map where it is arising so that we can plan our surgical route accordingly and avoid any unnecessary coagulation of this. Because you blow this up and all you have is a huge infarct post-operatively in the spinal cord, and the patient is going to be rendered with irrecoverable loss. So, spinal astrocytomas. They are the most common intramedullary spinal cord tumors in children and the second most common in adults, following the ependymomas. Let's see, they are infiltrative. We already know that. Hence, the surgical plane is not clear. When the surgical plane is not clear, this means that GTR is precluded. You are not going to plan GTR in these patients. You are going to know very humbly as a surgeon that MSR is going to be your go-to here. And you will stop when you think that tumor cord interface has been reached. So the WHO grading system stays the same for the spinal counterpart. Can somebody go over it quickly? Anybody remembers astrocytoma WHO grading? No, it's easy. Grade 2, grade 3, grade 4. Grade 2 and 3 can be defined histologically. Grade 4 can also be defined histologically with necrosis or with microvascular proliferation. And there is a molecular abnormality that renders any grade 2 or 3 into 4, CDKN2A or CDKN2B. So if you find this molecular abnormality within the grade 2 or grade 3, it's automatically going to upgrade the tumor to grade 4. Are we clear till this?
Yes.
We have all covered astrocytomas in a thorough session as well. Hence, I am choosing to stay very selective. Molecular biology stays the same, understandably. IDH mutation is a diagnostic requirement to establish that this tumor is astrocytoma. The grades remain the same. The molecular biology remains the same as well. Okay. The pediatric presentation for the spinal astrocytomas is slightly different from the adult presentation. Why? Because pediatric spine is growing very rapidly and it is flexible. What do I mean by flexible? It means that it's prone to get scoliosis, it's prone to get torticollis. There can be gait changes very early on, whereas
No. Scoliosis is because why? What happens? Because it compresses the central column nerve roots. The central column, all the extensors will come. All the extensor will come in the medulla. So whenever the central column tumor like ependymoma compresses, the extensors are get compressed, so it flexes to become scoliosis. Scoliosis because of that in central cord tumors. I have seen many patients, ependymoma pediatric patient, they develop scoliosis.
Yes, but even if that is not involved, patient can still have scoliosis and torticollis both. Part of the reason is that the CSF dynamics is disturbed. And yes, you're right, extensors are affected. They can lead to poor posture and
So
they can cause
when
scoliosis.
extensors are weaker, then flexors will overact it. When
But why do
extensor
you
of
think that is specific for pediatric population and not in the adult population? The adult population also
because
has.
adult population also have scoliosis I have seen in my center, but
Mhm.
pediatric population why it is more because it is a growing phase of the bones. All the bones are in a growing phase, so only it happens. I have seen both adult and pediatric population in my center. Our
Okay,
center is one of the high volume centers in India. Like
okay,
so, I have seen many patients having scoliosis in the central cord tumors, long
okay.
segment tumors having scoliosis.
Dr.
And
Shubham, when we talk, okay,
yes, madam.
sorry, you can continue. I'll talk later on. Yeah.
Yes, madam. Actually, my head of department tells that is because of the extensors are in the center, because the tumor grows in the center, so it compresses the extensors, so the flexors overact and make the spine curve flexes to one side, so it becomes scoliosis and kyphosis also sometimes.
Yes, you're
Thank you,
right.
madam.
What I mean to say is when we talk about the general presentation, we do not take a single institute's experience, right? Because a single institute's experience can differ in terms of presentation, it can have a lot of other variables as well. Scoliosis is not a common presentation in the adult population. Why? The primary reason still says because the spine is now relatively fixed. It's not growing as rapidly. So yes, the extensor and the flexor tone depends. It is also one of the driving factors. But the other reason is that the spine here is growing very quickly and it's more susceptible to any changes in the muscle tone. The muscle tone is compromised in the adult population as well. So whenever we talk or discuss the presentation, we talk on the basis of published literature and not a single institute's experience. So
Uh,
moving on.
In my institute, patients come from all the Gulf countries, Bangladesh, everywhere patients comes to CMC Vellore. It's not from India only patients comes. And my head of department only taught this. I don't know how much
No,
he's the
no, no.
one of the
I'm
best
not.
lead.
Please let me be very clear about this. I appreciate your input, and I'm not saying that it does not happen. I'm only saying that the tone theory is right. It's right, essentially. What I mean is that it's a single center institute still, a single institute's data, and I'm not sure if it's published or not. Astrocytomas presenting with scoliosis as a primary sign in adults is still unheard of in most of the literature. But I am interested, if you have any published data, you can share it with me. I'm not negating what you're saying. So let's move on instead of focusing on this one. With children, we see a regression of milestone as well. You can have, regression of toilet training. You can have parents who are coming to you and complaining that the patient was walking initially, but now they have stopped walking, they have gone back to crawling, or their gait has changed. Or oftentimes, these patients might also present with multiple episodes of falls. Right here. So multiple falls can also be an initial presentation. Then there is a higher incidence of hollow cord involvement. Can somebody let me know what is hollow cord? Anybody? No? Okay, by hollow cord, we mean that the entire cord is affected, or at least a majority of the portion of the cord that is affected, whereas in the adult population, it is usually localized to a specific segment. Then coming to the pain, children are very, very poor communicators of where they exactly have the pain. And that is one of the primary reasons the presentation and the diagnosis can be very delayed, because the patient can keep getting referred here and there since they are not clearly articulating. Whereas in comparison, adults are going to obviously pinpoint where exactly do they have pain, or even if it is dysesthetic, or they have paresthesias, etc., then they are going to let you know. So diagnosis is significantly delayed in the pediatric population. The good thing is that the tumor grade is often lower. What I mean by grade 1 here is pilocytic astrocytoma, or grade 2 astrocytoma IDH mutant. What ends up happening is, since they are slow growing, even if the patient is deferred here and there, the damage is not as much. Whereas in comparison, grade 3 and 4 are much more common in the adult population. Are you all with me till this?
Yes.
Okay. Apparently we are going very slow. Let's go on to the diagnostic nuances. So in children, painful scoliosis. Please note that the term is painful scoliosis, or a curve that progresses rapidly without a clear cause should be considered a red flag, and a patient should undergo investigation. Also, unlike idiopathic scoliosis, the tumor-related curvature is often associated with neurological findings, however subtle. Hollow cord involvement, I already mentioned. Pediatric astrocytomas can occasionally span the entire length of the spinal cord. And why do they remain functional? Because children have one thing which is called plasticity. It's a gift that adults do not have, or at least do not have in the same capacity. So a child may reach you very late, and a child may have extensive spinal cord involvement. Because of plasticity, they are still way more functional in comparison with an adult counterpart. So diagnostic delay, I have already discussed. I'll just skip over it. Nocturnal pain. There are two theories. One of them is because there is venous congestion. When a patient lies, there are gravity associated changes, and hence the tumor and the region around the tumor has venous congestion, which leads to pain, which is worse at night. Or it is also associated with recumbency. When a patient lies down, because this also happens when a patient lies down, it is not associated with night only. It is a pain that happens in the recumbency. And then there are changes in the CSF pressure around the tumor site. Nocturnal pain is a feature of both the extramedullary tumors and the intramedullary tumors. So the radiology, you can see that it is a very diffuse tumor. These are the sagittal sections, cervical spine, MRI, and T1. You can see that the CSF column is intact. The core is diffusely involved. You can also see syrinx, which is extending up to the C2. And I do not have contrast enhanced image for this. But this has a very characteristic finding, which is called pregnant cord, a word that I mentioned. This is a sagittal section, T2 weighted MRI. You can see that there is a diffusely infiltrating lesion within the cord that you cannot mark the boundaries of. It is ill-defined, and there are signal changes which are extending way above the actual margin of the lesion. You can see that the dorsal cord and the upper cervical cord both have signal changes in there. And there is complete obstruction of the CSF column. What is this? Which phenomenon is this? I previously mentioned it.
Hollow cord.
Polar cord, that's right. Okay, somebody has written in the chat box, polar cyst. That's right. Polar cyst is a specific feature of, anybody who has gone through other sessions will know this.
Ependymoma.
That's right. Polar cyst is a characteristic feature of ependymomas. It is not as common in the astrocytomas, but it can, still happen. Radiology can be very unreliable and very deceiving. Always remember this. So this here is polar cord. You can see significant involvement of the entire spinal cord length. There is another interesting thing going on. What do you think is that? Can anyone comment? It's visible.
Kyphosis.
Yes, there is abnormal spinal curvature. You can see that. The dorsal kyphosis is very enhanced here. This is not normal. So polar cord and excessive curvature. What does this make you think the child's? Oh, I already said that it's a child. I purposefully did not mention that this was a pediatric patient, but it is. Let me move on. So you can see this is another sagittal section, and the lesion is visibly involving from approximately C3, C4, starting from C4, going down the dorsal spine as well. There are multiple cystic cavities within the tumor, and you cannot adequately differentiate the tumor and the cord interface here. So the surgical strategy for intramedullary tumors. Laminoplasty versus laminectomy. This is the pitfall for pediatric patients because it is growing a spine. You want to avoid laminectomy strongly because it is going to cause post-laminectomy kyphosis. Whereas in adults, you can still go for wide laminectomy, especially if it is dorsal spine. Dorsal spine is way more forgiving in terms of how much you're taking out. Dural opening. The dura should be opened midline, tacked back tightly to maximize the surgical corridor. Then the myelotomy. When it comes to myelotomy, there are two options. You can either go midline or you can go off midline or the paramedian, which is the dorsal root entry zone. Why is that? Can somebody mention?
Avascular.
Yes, we go in the midline. A midline myelotomy is the standard approach because it is a natural plane. It's an avascular plane. When would we go midline and when would we go paramedian? It's a very common sense thing. Yes, somebody wrote eccentric tumor. When a tumor is, you always remember what you're addressing here. If a tumor is here, obviously you're going to go midline. Whereas if a tumor is here, or let's say here, if you go via the midline approach, you are going to risk all the uninvolved tracts while you are reaching the tumor because you will have to retract all of this. So what is a better option? A better option is to go where the tumor is located. So midline myelotomy is still the standard approach. Dorsal root entry zone myelotomy may be considered to minimize damage to the dorsal columns. Moving on.
How to know dorsal root entry zone? I want to know.
Sorry, who is that?
I'm Dr. Subham. How to know that dorsal root entry zone?
Oh, we know this. We first identify the midline, and then we see where the root is entering. In fact, the root is leaving the theca, right? If you can see here, Let me draw. The root is somewhere here. These are the tech-ups, by the way. These are not roots. The root is going
These are the
to lead.
data holding.
Sorry, who is this?
Uh,
Please
yeah,
introduce yourself when you talk.
Yes, madam. Continue, madam.
So when the roots are leaving the thecal sac, they are visible. So you need to
Okay.
identify the midline. This is here. And then you need to identify the paramedian sulcus where the roots are exiting. Once you can see that, for example, the roots are exiting here, you're going to go slightly medial to this, the dorsal root entry zone. Once you identify the medial zone, you're going to enter via the tract of fissure. The tract of fissure is a safe tract in comparison of, how you enter in the spinal cord. I have an image. We will go over it. Midline myelotomy, we utilize the posterior median sulcus. We identify the midline. How do we identify it? There are posterior spinal arteries. You can see the posterior spinal arteries, they are paired. They go like this. Then we have to go in between them. There's a very narrow space where we go in between. This area is avascular. It's a natural plane. We open the arachnoid and then the pile surface is incised exactly in the midline. Bipolar is going to be your biggest friend, but your biggest enemy as well when we are talking about the spinal cord surgery. Okay, now you can see that this is the posterior median sulcus, the avascular zone. This is the posterolateral sulcus where we have tract of Lesor. When we are talking about the tract of Lesor, you can still, damage the cell bodies that are specifically in this tract of Lesor. But comparative to the other entry zones, this is still a safe area. We only go via here when the tumor is paramedian. So this is the eccentric approach. The incision is made just medial to the point where the dorsal nerve rootlets enter the cord. This goes through Lesor's tract. There is still a risk of localized radicular sensory loss. I went through it. Patient can also have deafferentation pain or neuropathic pain because it crosses the entry point of the sensory roots. Now, whoever asked the question, I think they will have it clear by now. I'm sorry, I have turned off the participants section up, so I cannot see your name when you talk. You can see that this is the posterior median sulcus and this is a midline myelotomy, whereas this is where the dorsal roots exit the theca, and on the cord, there is the sulcus just medial to their, let me draw, just medial to this portion. This is where we make our myelotomy. So this is where the dorsal root entry zone myelotomy is done. Am I clear till this?
Yes, ma'am.
Okay, moving on. So this is another image. It just enhances what I previously said. This is tract of Lesor. You see that you're going through these cell bodies. So there is a risk of deafferentation pain. It's not significant, but still. And this is actually a picture of dorsal root entry zone lesioning, but it serves the purpose. This is going to be our surgical corridor right here. Okay, the resection strategy is slightly different. When we talk about intramedullary lesions, you biopsy from the most superficial part, then you debulk it internally using a CUSA. And when the tumor cord interface is approached, stop. What do I mean by tumor cord interface? You have done most of the debulking. Now you do not know whether the tissue you're looking at is the tumor or it is the cord. Because for infiltrative lesions, often the interface is not very clear. Hence, maximum safe resection is superior than cross-total resection in terms of clinical safety. Please know that by this, I say clinical safety, not the outcome. With the outcome, GTR is obviously going to be superior. MSR is still going to be superior in terms of the clinical safety. If it is an ependymoma, are still more forgiving. They have often an intact plane or often an intact tumor capsule. So you can bravely attempt a GTR in ependymomas, but it's a very poor surgical strategy in terms of astrocytomas when you attempt prosthotal resection. So, intraoperative neuromonitoring, this is your surgical compass. You are going to need MEPs, you're going to need D-wave monitoring. MEPs are most sensitive, but D-wave are the best help in terms of long-term prediction. So, if there's a sustained 50% drop in amplitude or a significant increase in threshold, stop. That is a hard stop. That is a non-negotiable stop. Then we have D-wave monitoring. So, even if you lose MEPs during the surgery, if the D-wave is intact, the long-term prognosis is going to be good. So, what are you going to ask your anesthetist to do? You are going to ask them to monitor a map like anything, because when you are operating on the spinal cord, and especially the dorsal spinal cord, they are very sensitive to even minute pressure changes. And if there is a significant drop in MAP, the patient might end up having a post-operative cord infarct. So how much MAP do you need? You're going to need 85 to 90 mm mercury. And even a transient drop, for example, during induction or position changes, can be catastrophic. So you do not only have to keep an eye on the intraoperative neuromonitoring, you also have to, at least your anesthetist has to keep an eye on the map. So what also happens is, if the map drops, it might lead to decreased MEP amplitude, which can create a false positive. It can make us think that we have reached a functional tissue and we need to stop. So there can be a false alarm. And when there is a false alarm, it can lead to subtotal resection unnecessarily. And this is a pitfall that is avoidable. So if MAP is MAP map, if that drops, then your MEP map also gets affected. So we know spinal cord has notoriously precarious watershed areas, especially in the dorsal spine. And even if there's mild hypotension, hypoperfusion, these areas can develop infarcts and postoperative edema. So what is the post-op strategy for intramedullary tumors? Even after you have operated the patient, you still need to keep an eye on MAP. How do you address the cord edema for the 24 to 48 hours? High-dose dexamethasone. You still need MAP over 85 mm mercury. Subacute stage, it needs neuropathic pain management. Gabapentinoids are often started early. For the long term, you need stability, specifically in the pediatric cases because that is growing spine, but also in the adult patients where you have resected significant amount of bone. Are we clear till this? Because we are moving on to intradural, extramedullary. Any questions?
Yes, madam,
Okay.
clear so far. Yes, ma'am.
Sorry?
We are clear so far, madam.
Okay,
Understood.
thank you. We are moving to the intradural extramedullary tumors. Let me see, I'll try to complete this today. So we have schwannomas. Their clinical presentation is very typical. We all know that radicular pain, that is their hallmark. The patient comes to you and says that there is severe pain and that is radiating anteriorly towards their abdomen, or it is going down their leg, or it is, for example, if it is cervical, then it is going down their arm. So the radicular pain is a typical presentation. It's worse at night. It can be worse with Valsalva maneuver, cuffing, stazing, etc. Nocturnal pain we have already discussed. Why is this common? It is common because when a patient lies down during recumbency, what ends up happening is the nerve root gets stretched. Once it gets stretched, the pain fibers get activated. So nocturnal pain and the radicular pain, they are both going to be the hallmarks. There is centrifugal sensory loss, early sacral involvement, feet first, arms later. Then we have the brown sacral involvement because they compress one half of the cord. And yes, ipsilateral motor loss and contralateral pain and temperature loss. I completely forgot. I don't know what happened to me. So we have schwannomas versus neurofibromas, a very, very commonly asked question, and often where a lot of residents get confused. I think this makes it pretty clear. I do not need to say anything after this image. You can see that neurofibromas infiltrate the nerve fibers. Let me draw here. If this is a nerve fiber cross section, and this is the orange thing is the tumor, then this is the schwannoma. So it might lead to compression of the nerve fascicles. Let me draw here. So the nerve fibers can go flattened like this, right? But the nerve is in its own entirety, it's not involved. Whereas when we talk about neurofibromas, it's going to infiltrate the nerve, and what you're going to see is a big block of neurofibroma and the nerve itself. So this lesion is, it's not completely resectable unless you're going to sacrifice the nerve root or whatever nerve or rootlet it is arising from. Whereas you can attempt to gently peel this off this nerve root, and it is salvageable. But what is important to remember is, even if it is salvageable, oftentimes due to pressure, necrosis, this rootlet or root has been rendered completely useless. So this is a very small comparison table. There are histological differences as well. I thought it would take a lot of time, hence I did not include that. For schwannomas, you have a true capsule. With neurofibromas, there is no true capsule. Schwannomas displace the fascicles. Neurofibromas infiltrate and incorporates the fascicles as it grows. Then we have the resection type. With schwannomas, you can do a nerve sparing surgery. With the neurofibroma, you have to take the nerve away. NF2 and schwannomatosis are associated with schwannomas, whereas NF1 or von Reckling-Hossen's disease is associated with neurofibroma, and neurofibromas have a higher risk of malignant potential. Schwannomas can arise from both the sensory and the motor roots, whereas, yes, neurofibromas can also arise from sensory and motor. I'm sorry, it says mostly sensory. It can arise from the motor roots as well. So it's a beautiful looking lesion, dumbbell shaped, not the classical dumbbell, but still you can see that it's well circumscribed and homogeneously enhancing on the contrast. You can see the intraforaminal part. This is the foramen. This is the neural foramen here. This thing. This is the intraforaminal part. The lesion is extending out of the neural foramen, and soon it is going to involve the paraspinal tissues. This is also a schwannoma, but it's difficult to tell on this single image. This can easily be confused as a meningioma as well. So these are the upper row is all sagittal sections, lumbosacral MRI. You can see that there is a lesion which is well circumscribed, involving the vertebral body, also compressing the theca and the conus here. No, in fact, it is way below the conus. It's going to involve the cauda equina. And let me see the axial section. Okay, so you can see that it is involving the vertebral body, and it is going out of the neural foramen and involving the paraspinal structures, but it has not gone so far as to involve the psoas muscle. Usually, when these lesions present, what I have seen in the practice is they often involve the psoas as well. Hence, the resection becomes really, really difficult. Okay, so you see a dorsal schwannoma here, which is not a classic dumbbell, but still, I think it would do. You can see that this is the foraminal part. This is the intracanalicular part here. And this is the extracanalicular part here. I'm sorry, due to constraints of time, I cannot go in the radiology in detail. Unlike the other sessions where, we discussed radiology at length, you can see that this again is a lesion which has an intracanalicular compartment, And then we have this intraforaminal compartment. And then we have this paraspinal compartment that is now significantly involving the paraspinal musculature. As a surgeon, you are going to hate this lesion because it's going to prove very difficult in terms of complete resection. Astrocytoma classification. So, I don't know how many times I have read this, how many times I've memorized this, I still end up forgetting it. Let's hope we all can go over it together. So this is type 1. Type 1 is easy. It is intracanalicular. What do I mean by intracanalicular? This is the canal. It stays intracanalicular. And where's the constriction? The constriction is at dura. So you have an intradural and an extradural portion here. There is no foraminal portion at this point. Type 1 is intracanalicular and the constriction is at dura. Whereas type 2 is extradural. There is constriction at the foramen. You can see that this is the foraminal compartment. There is a constriction here and the lesion is completely extradural, pushing the theca over one side. This is type 2A. Type 2B means that this lesion is now ballooning outside. Okay, this is the intracanalicular extradural, then the foraminal, and then the paraspinal or the extraforaminal portion of the tumor. So if you can imagine this, then you can imagine this. Type 2A, intracanalicular, foraminal. Type 2B, intracanalicular, but also goes out of the foramen in the paraspinal region. Are you all with me or lost?
Yes, madam, with you.
Okay. Type 2C is there is no intracanalicular portion now. There is only a foraminal portion and a paraspinal portion. So when we come back to it, let me see. Type 2A, intracanalicular and foraminal. Type 2B, intracanalicular, foraminal, paraspinal. Type 2C, foraminal, paraspinal. We move on to the next one. So this is type 3. Type 3 has a lot of constrictions going on. You can see that there is a constriction at dura, then there is a constriction at the foramen. Dr. Sampath, please do not annotate on my screen. Then we have type 3B. The constriction is at the dura. Then there is a constriction at the foramen. And there is another constriction where the foramen ends and there is a paraspinal segment. Then we have type 4. There is a constriction here, right where the canal ends. It is still extradural. And then it goes in the intervertebral body. So when you're operating on these tumors, once you take out the portion in the body, this patient probably will need a graft or a cage placement in the vertebral body. Then we have type 5, where it is extradural, but intracanalicular, and it is crossing the lamina to come out on this side. Type 6 grows like an amoeba. It grows in all directions, probably the easiest one to remember. It grows inside the vertebral body, it goes outside the foramen, and in the paraspinal region, it also traverses the lamina and grows in this direction as well. Why is astrocytoma important? Astrocytoma was important because we want to understand the surgical approaches and the strategy. The posterior approach is a standard. Where is it applicable? Types 1, 2A, 3A, upper cervical 3B, and 6. Let me go back. This is 1, 2A, here, 3A, sometimes the 5 as well, and you are going to go posteriorly. Let me draw. You can go posteriorly, take out the lamina. Sometimes you can also take out part of the facet. There are types where you will need facetectomy, sometimes partial, sometimes complete facetectomy. And once you remove the facet, you are going to have access to the foraminal compartment. And if you can resect this in entirety, this one is easier. You only go posteriorly, take out the lamina, then you can take the lesion out, both the intradural and the extradural compartment. Okay. So 2A and 3A often require total facetectomy to visualize the extraforaminal component. What happens if we do a total facetectomy? Can somebody tell me?
Joint instability happens.
Sorry?
Kyphosis, post-op kyphosis can develop.
Mm,
Dr. Subodh.
okay. And what else can happen? A
Listhesis,
good
madam.
answer would have been where the site of the surgery was, because patient is not going to have a kyphosis if it was lumbar spine, right?
Listhesis will happen. Yeah.
Yes, if it is lumbar spine, then total facetectomy is going to lead to spondylolisthesis. So a good answer to this question would be a total facetectomy is going to produce instability in the spine, and you will need fixation and fusion after you have done the tumor resection. So coming back, where are you going to use the posterior approach? Type 1, intradural. Type 2A, type 3A, upper cervical 3B, and 6, where it is multi-level. 2A and 3A are often going to require total facetectomy. Reconstruction is really important if you have taken out more than 50% of the facet. Where are you going to use the anterior and the combined approaches? Some of them very, very clear. If it was involving the vertebral body, like type 4, if there was type 6, type 2B, 2C, 3B, these are the lesions where you are going to use the anterior or maybe a combined approach, anterior and posterior both. So when we are dealing with large masses, where the nerve and tumor interface is obscured, you cannot exactly see where the nerve root is and where the tumor is. A good idea is to first see if the nerve is even functioning. Please keep yourself muted. So, as I previously mentioned, that what happens is even if schwannomas leave the nerve fascicle alone, because they are under significant compression for a long time, they are often rendered useless because other rootlets or other roots, they end up taking their function on as well. So we first need to identify whether the nerve is functional or not. A non-functional root can be sacrificed in worst case scenario. Internal debulking is again a go-to thing. You're going to do a capsulotomy, and then you're going to debulk internally just like you would have debulked a meningioma. And then what happens? The tumor capsule collapses on itself, and then you can gently peel it away. And if it cannot be peeled away, you have two options. If the nerve root is functional, you leave a small residual. If the nerve root is not functional, then you can sacrifice it. Functional compensation, I have already gone through. Adjacent roots frequently take over the dermatomal and the myotomal distribution. So even if you end up taking away the rootlet, there may not be a new deficit. And the 50% rule for facetectomy, I strongly believe we have discussed this in another session, but I was not sure, hence I decided to include this. If the partial facetectomy is less than 50%, because the foraminal portion of the lesion was not big enough, then you can get away without the fixation. But if it was a total facetectomy and cervical spine, you are going to need fixation with lateral mass screws. Or if it is lumbar spine, then pedicle screws. With dorsal spine, you can still get away, provided that the rib and the costovertebral junctions are intact. Yeah. So if it is only medial facetectomy, less than 25%, you don't need to do a fixation. If it is partial facetectomy, 50%. For cervical and lumbar spine, you are going to consider strongly. For dorsal, you can still get away with it. If you have done total 100% unilateral facetectomy, For cervical, you are going to fix it with lateral mass screws. For lumbar, use pedicle screws or whatever you think is necessary. For dorsal spine, you can still consider at this point. Whereas if you have done bilateral facetectomy, I think it's pretty obvious that patient is going to need fixation. If you are not fixing, in the lumbar spine, patient might have a spondylolisthesis later on, which is going to be just as big of a problem as the tumor itself. So meningiomas, the most beautiful lesions because they're very easy to understand. They're very sweet, even from a surgical point of view. And I would just briefly go over them and we will call this a day. Clinical presentation, obviously very typically seen in women aged 40 to 70 years. Symptoms often progress over 1 to 2 years before diagnosis. Axial pain is the most common initial symptom. Progressive myelopathy, because the cord is getting compressed for the long time. Brown-Sequard syndrome. Radiological presentation is also very typical. You're going to see a well-defined, homogeneously enhancing lesion, which is causing compression over the cord. There is going to be a dural sign, not always, but it can be there. Calcification can be there. And thoracic spine is a much more common location in comparison with cervical or lumbar. So you can see that these are sagittal sections, a well-defined lesion, and these are T2 weighted images, well-defined lesion at the level of probably lower cervical spine. I cannot count the level. It's either C7, most likely C7. And it's compressing the cord completely to the opposite side. It's a ventral lesion and obscuring the CSF column here as well. You can see that these are post-contrast images of the same lesion, and there's a subtle dural tail here and here as well, which is a giveaway of this being a meningioma. This technically still gets counted as a foramen magnum meningioma, but the imaging looked interesting. That is why I included it. You can see that it is compressing the cord to the opposite side. It's ventral. Ventral meningiomas are, they can be a very, not exactly difficult, but they can still make surgeons apprehensive. Whereas if the meningiomas are posterior, then obviously the surgical risk is way less. On the coronal section, you can see that the cord is compressed here. So this is again a foramen magnum meningioma, but this is a posterior lesion. The cord is compressed anteriorly. The dural tail is not as significantly visible, but the location is typical for meningiomas. Here you can see the dural tail both on the upper and the lower pole, and you can see how the cord is draped to one side, whereas the tumor is occupying the entire canal. Surgical strategy is simple. If the lesion is posterior, you go via posterior approach, posterior laminectomy. If the lesion is ventral, now you have other options. Do not retract the cord, because if you are retracting the cord to reach the ventral meningioma, it may lead to post-operative cord infarct despite having a complete resection during the surgery. What do you do to the dura? You have all the options depending on the case. If there is significant dural base involvement, you can take it and repair it with the help of a graft or a pericranium or fasciolata, depends what is your institutional practice. Then if significant amount of bone is involved, you can take it out and proceed with graft placement or reconstruction. The other option is Simpson's grade 2. You can go ahead with total resection with cauterization of the dural attachment. You can also go for grade 3, where you leave the dural base as it is. This usually happens when the dural base is inaccessible. Meningiomas give a beautiful arachnoid plane. You have to preserve that. It's going to protect the cord and the bile vessels. And dural reconstruction. If you resect a large patch of dura, you must perform a duroplasty. And that's a wrap. It really felt like a marathon. I do feel like I have run a huge marathon. Thank you so much, everyone. All feedback and questions are welcome. There is just a small request, in fact, 2 requests. Please keep yourself muted while you're attending the sessions. It disrupts my thought process. And the second feedback is, please avoid going into extensive discussions about your particular institutional practices because it takes away time from the session and it ends up getting prolonged unnecessarily. That's all from my side. I'm still welcoming all feedback and all questions. And if you cannot leave here, then you can leave on the WhatsApp group. Thank you so much, everyone. That's a wrap.
Madam, I want to ask a question, please.
Dr. Abid, please keep it short because we are really late.
Yes, madam. Madam, a small question. What is the treatment option for hollow cord tumors when it is involving the whole of the segment of the
For hollow
cord?
cord tumors, surgical management is not going to make much of a difference. What you can
Yes,
do
ma'am.
is you can plan a biopsy. You can plan to take out the major portion of the tumor, which is easily accessible, and then you're going to leave rest of it behind, and you are going to go for the non-surgical options afterwards. That is the chemotherapy and the radiotherapy. Surgical management is not going to play a significant role apart from probably giving maximum safe resection, which is the goal, obviously, and the molecular biology, which is a big thing in the current glioma treatment.
Thank you so much, madam. Thank you.
Thank you. Thank you so